Okay, let's talk about myths. This is kind of a quick little ditty lecture that's kind of fun, nice way to wrap, that talks about myths in emergency medicine. And one of Rick's things, and actually it's a kind of a thing out in medical education, is to look at things that we've done forever, or you've been told, and find out what's real and what's not. One of the things we've already kind of referred to in myths, we referred to on the panel, which is the idea that you can't give that tetracaine to people with a corneal abrasion that are having pain. And the reality is, one of the just side, I'll go into the other myths in a second, but one of the side parts of that is the approach that Billy mentioned, which is what we do at our place too. You don't really just prescribe it. You kind of just leave it there and mention that it's going to get tossed and because your ophthalmology colleagues right now will take you down if they know that the patient got tetracaine from you with your blessing and there is a complication down the line. There is no correlation between the two. Okay, know that corneal abrasion, sometimes there are things that go wrong with most, rarely, but if you've given the tetracaine, there's no correlation between the tetracaine and the bad outcome. But if there is a bad outcome, your ophthalmology colleagues will take you down. So just don't even mention it, but it's absolutely fine to sort of have it walk with the patient when the patient leaves. And eventually, hopefully, our colleagues will step up to the plate. Similar idea with injecting sort of the fingers, toes, penis, nose, don't use epinephrine with lidocaine stuff. It turns out, at least in digits, it's what our hand surgeon colleagues do all the time during the operating room. They do it all the time. And God bless one, I believe he was a hand surgeon, wrote an editorial not that long ago, probably 3 years ago, that basically said, I have thousands of cases in my practice of doing this as a routine. There is no downside to doing this, at least with digits, as long as the patient has both arteries that are working, and most people do. They don't have any reason not to. It's fine to do. So I haven't completely changed my practice. I do this in younger people now. You go ahead and use epi with digital blocks. As people get older and vascular disease becomes more of an issue, I'm a little more hesitant. I can't base that on anything, except know that that's another myth. This idea that can't use epi for digital blocks, at least in the fingers, is not true. Okay? And by the way, if you happen to get some vasoconstriction, usually it goes away just fine when the epinephrine wears off, which is actually a couple of hours, and it's usually just fine. It doesn't kill the finger. So, all right. What Rick chose in this particular section of myths to attack are urologic myths. So he kind of focuses on the urologic tree. You have a bonus here at the end as well. But he focuses on urologic myths. So the first one he throws out there is that patients with recurrent suspected kidney stones need to have a CT. The reality of this is no. And we know that working up kidney stones, we have basically 4 things in our bag of tricks. One is nothing, okay, no imaging whatsoever. One is KUB, which was kind of the old-fashioned way of doing it, which has now had a bit of a resurgence, I'll tell you. One is ultrasound, and one is CT scan. And the reality is, our job, honestly, is to make sure it's a kidney stone, that it's not something scarier, to see if that kidney stone is infected, and to get them referred for follow-up. That's our job. Our job is not to determine the size of the stone every time they have a stone, and 10% of the US population, or North American population, has kidney stones. 10%. 10% at some point in your life you're going to have a kidney stone. That's a lot of people. And kidney stones tend to be a recurrent disease. It's not like you get it once and you're done. It tends to be a recurrent disease. So it actually does make a difference how we approach this, as far as at least radiation risk. So most people, the first episode of stone, most people will go ahead and actually get a study, and will get a definitive study that will rule in the disease. So it's helpful if somebody has you're getting a couple of things also with, and most of the time it's a CT scan, the first stone. And the argument that can be made for that is not just that you figure out that they actually have the disease, you find out how big that stone is, you get the hydro, all that jazz. You also will find out with that first time, let's get a CT scan approach, that they have 2 kidneys. You'll find out if there's any other anatomic abnormalities. They have a pelvic kidney, they have double ureter system, which some people do. Actually, it's a relatively common congenital thing, to have double ureter system. And you'll basically find out if there are other disorders going on in there. If there's something else that might be causing that discomfort. So first time episode, I'm not sure if it's a stone or not, CT scanning, is actually not a bad approach. It's the second time and every time thereafter that it becomes an issue. There's a paper in here, Broder, that's abstract number 1, that looks at how many people, when they have a history of kidney stones, have had multiple CT scans for their kidney stones. Basically, these are all people, the median age in this study was low. It was 39. It was pretty young, healthy people for the most part. It wasn't like this was all 65-year-olds where you were worried that maybe it was an aneurysm this time. These were young people for the most part. Half of the people in this study had gotten 2 or more scans, and one poor bugger had 25 CT scans. 25. There's no excuse for that, absolutely none whatsoever. And one of the pushbacks we're getting in our joint, and I'm sure you're getting the same, is even in the recurrent stone, it's he had his first stone at 25, it's a guy, he's 28, he has classic symptoms, it's flank pain, it radiates colicky, the whole thing, classic symptoms. One of the pushbacks and we tend to use ultrasound, I'll talk about in a sec, just to confirm that it's there today. But one of the pushbacks we're getting from our urologists is, well, I want to know how big that stone is. Why? Honestly, today, why? I know, you know, they know, 6 millimeters or greater, the likelihood of truly passing drops significantly. 5 millimeters or less, the odds are they'll pass it, it'll be miserable, but they'll pass it. Their argument is, I want to know, so I have some idea of how to approach this patient. My argument is, if it's that big, they'll be back. Okay, they'll see you, they'll have recurrent symptoms, they'll be back. Okay, and I'm not going to knock off, even if they're totally obstructed. I have a week before I'm ever going to affect the renal function in that kidney. So there's no need for me to radiate this young, healthy person today. As long as their urine isn't infected, I don't even necessarily need to image them at all. They can follow up with you or their primary care doc if they have recurrent symptoms and it can't be controlled, they don't pass a stone in a week, then they can come see you. And we can go ahead and consider getting a CT to see the size of the stone then. We're having a lot of arguments with our urologists right now, but honestly, what happens if you take that approach is a very significant proportion of the patients never need to be imaged because they pass the stone and it's done. You're finished, it's over, you're done. So part of this is our being sort of stewards of not overutilizing radiation in people that have a disease that I know for sure is recurrent. The odds are extraordinarily high. They're going to get at least another episode or God forbid, 25, like that poor bugger did in this particular paper. So CT scanning just for stone size, I have a lot of trouble with if that's the argument. I have a lot of trouble with that. Is ultrasound better? Oh, go ahead.
How about if they have the symptoms for a week?
So that's a good question. So actually, that's a very reasonable question. So what if they know they have kidney stones, they knew they had one, they've already been home a week, and that actually you can make an argument. Because if the stone is big, and they really have been truly complete hydro for a week, although the odds are it hasn't been for a whole week, true total obstruction, the pain doesn't usually just come and go. It comes and it stays. They're pretty miserable and they don't last a week. Those people who come in really sick where we can't get their pain control. But if it's been a week, then you can make an argument to see. But I start again with an ultrasound. Okay, I'm going to start with an ultrasound and see if they even have hydro. If they don't, now I've got something's funny here. Something's funny here.
Yeah, and I also do a KUB because that's
right.
A lot less radiation.
So KUBs, the KUBs kind of fell totally off of our order set for just about everything. It used to be stones and obstruction, right? That was what we were, and free air. So we were ordering, and it turns out chest x-rays are better for free air, and actually technically CT scans are even better. And KUBs kind of fell off the map. I'll tell you where KUBs started to drift back in again. For some reason, stone disease is become, both gallstones and kidney stones, is becoming more and more common in children. Actually, remarkably more common in children. The youngest person I know of who had gallstones diagnosed was an 11-year-old in our ER relatively recently, and kidney stones can be down to much younger. So this got back onto the sort of plate because particularly in children, you can get a KUB, see if there's a stone or not, because they don't have all those phlebolysis and stuff yet. If there's a little piece of calcium there, it's in their ureter. If it's in the right sort of distribution, it's in their ureter. There's not all this confusion of could this be a phlebolysis, like us old folks have all that calcification. So it came back on the map for that. And it turns out that particularly the younger patients, it's pretty decent at seeing if there's a stone and you can measure it, which is kind of cool. That's kind of nice, especially with our PAX machines. We can blow the thing up and get a really good measurement. You can actually measure the thing. So KUB is back on the plate. So KUB plus ultrasound will tell you stone, obstruction. So you get the two things with really minimal radiation to somebody with this. There are a couple of papers, now that you mentioned that, the next couple of papers look at how good is ultrasound and is it good in children. If you are relatively slender, so if your BMI is 24 or less, so that meaning that they can get a good ultrasound picture, right? There's not a lot of fat. They have a decent way of seeing your kidneys and seeing them well, and seeing the ureters, which is the other sort of two parts of it. What else? Let me back up. What ultrasound does for you, if you see things, is hydro, yes or no, and how bad. That's pretty easy. The kidneys are relatively easy to see. The other thing is stones, yes or no, and where are they? So for ultrasound for kidney stones to be in its best sort of information for you, it's going to tell you whether there's hydro, if there's a stone, and where it is. Okay, that's what it will tell you. It's very good at hydro. It's a little less good at true stones. And if you're a slim person, the odds are they'll see both. Okay, that they'll see both on that. If you're relatively young, it's going to catch 96 to 98% of not just hydro, but hydro plus stones. And children, unless they're little butterballs, it's actually wonderful in kids as far as being diagnostic for children. Remarkably so. There's a really wonderful study, abstract number 5. They did sort of what you would want someone to do to tell you how good is a test. They took the gold standard test, which is CT scanning. All of the kids, or 50 kids, all the kids got CT scanned, and all of the kids got ultrasounded. They used CT as the gold standard, stone yes or no, and then they looked at how good was ultrasound compared to that gold standard of CT. What they found basically in this particular study is that 68% of these children, these are all people under the age of 18, these are teenagers and younger, but about 68% had stones on CT. Ultrasound picked up 26 of those 34, and there were no false positive ultrasounds. So basically sensitivity was about 76%, it was 100% specific. If you see it, it's there. Okay, it's a real deal if you see it. Of the kids that were false negative, meaning the CT saw something, saw the stone, that the ultrasound didn't. And those kids were kids where the stone wasn't seen. There was no hydro in the CT scan group either, that group. But they couldn't see the stone well. It turns out those kids, basically, all 4 of those kids ended up having treatment. There were 8 kids. 4 of the treatment kids have no treatment whatsoever, just watched. The other 4 made no difference in their care. So bottom line, honestly, for me, when it comes to kidney stones, first episode, I go ahead and scan them. I want to confirm that they have 2 kidneys, make sure there's no anatomic abnormalities, see that stone, get an idea of the hydro, and say, yes, indeed, from now on, when you have these kinds of symptoms, you can say, yes, I had a kidney stone, they saw it on CT scan. And you tell that to the patient so they can take that down for the rest of their lives. Recurrent episodes, my job is, are they infected? So I get a urine, not for blood, I get a urine for white cells. Okay, that's what I'm looking for on the urine. I get an ultrasound mainly to see how much hydro they have, to have some idea of how much discomfort they may be in. And then I treat them and send them home with follow-up, often with their primary care physician. Our urologist have basically said, we're not touching them unless they have recurrence. So fine, that's whatever, they don't have to. So that's my suggested approach. KUB is particularly wonderful in children. It will also help confirm the stone. This is sort of up to you how you want to handle this, but it is, to me, it's pretty clear, and I don't want to radiate people a gazillion times for a recurrent disease. I'm just not going to do it. So that's sort of my approach. Any questions on that part? Because another myth when it comes to kidney stones is that what you do when somebody has a stone is you flood them. So you put in an IV, you give them lots and lots of fluids, it flushes that stone down the system. If we really step back a second, how incredibly stupid is that? Seriously. If you were completely obstructed on one side, it's not like putting a big pressure head behind it is going to somehow push that stone down. You have 2. It just gives the other kidney something more to do while its partner has a stone. It does not change outcomes. And in fact, there's some data, it's not in here, but some older data that says it actually makes pain worse to really flood them. It actually has I'm not sure I believe that, but I do believe that it doesn't flush anything through any faster. There's a couple older papers that look at this, but bottom line is it doesn't change their duration of symptoms. And in fact, there may be a smidgen of worsening of symptoms. So flooding them with IV fluids, flooding them with PO fluids doesn't make a difference, at least once the stone is there. You heard earlier about sort of expulsive therapy, this idea of using the drugs to make the stone go past, so I won't deal with that. I know that was in the lecture before. So overall, that's not a huge, I'll tell you, I don't know, did Jerry talk, I was packing when he was doing his talk. When he talked about the expulsive therapy for stones, did he talk about if you dose it, how to dose it? So our urologists now are all over tamsulosin. They all want it given to their patients. They all want, which is whatever, that's fine. However, if you're going to give tamsulosin, no, it's an alpha blocker. So it causes, especially with first dose, it can cause orthostatic hypotension significantly. So unless you want to convert a kidney stone into a hip fracture, I recommend that you give the first dose at bedtime. So rather than giving the first dose that they take at home, first thing in the morning, where they may have orthostatic hypotension and fall down, especially as somebody is older with stones, where they're more at risk of true osteoporosis and problems, have them take the first dose at night. That hypotension deal tends to kind of fade away with multiple doses over time, and actually relatively quickly. But that first dose is a problem. So tamsulosin, if you decide to use it, there's some people who say it doesn't buy you much, and it doesn't. If you use it, first dose at bedtime. All right, I love this one. So say you have a guy who comes in with urinary retention. He's been unable to pee for a couple of days, and now he's been totally unable to pee for 12 hours. Comes in, belly up to here, miserable, agony. Ultrasound shows this ginormous, 9-month version of a bladder. And you put in a Foley, and you walk away, and life is beautiful. And then someone comes up and says, "You idiot! How could you have done that? Look at that bag. Look at how much blood is in that bag. You even have a hemoglobin version of like a meniscus in there. There's a hematocrit to the amount of blood they've gotten in there. How stupid of you. Why didn't you just release it in 100 milligram aliquots?" What happens if you have urinary retention is your bladder, your detrusor muscle, gets stretched out, and eventually it just gets lazy. It's like, screw it. You stretch me out, forget it. I'm just done. I'm gonna be this big sack of blobbiness. And what's keeping the vessels kind of compressed is this huge amount of pressure in the bladder. The idea, this concept, I was taught this way back when. When you have somebody with that big of a bladder, you stick in the Foley and you just let out a little bit of fluid at a time, because what will happen if you let it all out at once is those vessels that are kind of juicy will basically decompress. A couple of them may rupture, and they'll just bleed like crazy into their bladder. You idiot, don't do that. Well, somebody actually went back and looked at physics and looked at hydraulics and looked at what really happens with the pressure in a contained space of a contained bag of fluid. What happens with the pressure? And you've done, those of us who work in trauma centers have done this with pericardiocentesis. If you've done this in somebody who has cardiac tamponade from having had, for instance, a uremic pericarditis or a malignant pericardial effusion, where they actually have a lot of fluid in there and they're hypotensive, you know that you can change the pressure in a pericardium by taking out as little as 100 cc's of fluid. You'll go from tamponade, death's door physiology, where somebody has a liter in their pericardium, you just take out 100 cc's and everything is beautiful. The same, there's still fluid there, but the physics of the hydraulics in there, it just takes a little bit of aliquot out to take that really distensing pressure down quick. Same thing happens in your bladder. The reality is, if that's stretched out like that, I just have to take out a smidgen of fluid, and the pressure around the inside of that fluid-filled structure drops dramatically. So it doesn't make any difference if you take out 100 cc's at a time or you just drain the whole bugger down, let it all drain out. It is the same potential risk. The other thing to know about hemorrhage after you drain somebody's bladder is that no one ever has died of that. It looks dramatic. It's this big bag of red fluid, and sometimes you really will have enough bleeding that there will be a little layer at the bottom, little sediment. That's your basically hematocrit in there. But it's never enough to kill you, even if you're on anticoagulants. Okay, even if you're on something like warfarin. Now, I can't tell you about the new ones. I don't know enough about the new ones to tell you for sure. They're just crazy stuff. But at least even if somebody on warfarin, don't worry about it. And go ahead and just drain it. The poor guy, let it drain, for heaven's sakes. It's absolutely fine to do. It doesn't cause any significant harm to do so. Ultrasound. Any woman in this room who ever had a pelvic ultrasound on an elective basis, if you had a transabdominal ultrasound, they made you drink a whole bunch of water, and then they sat you in that waiting room until you were incredibly uncomfortable, like this, walking in to get your ultrasound because your bladder was so full that, and of course now they're pushing on it, right? Oh, let me see if I can see anything here. It's like, oh my God, are you kidding? I have to pee. Do you need to have a full bladder for a transabdominal ultrasound? This is interesting. In the elective world, this is not our world. In the elective world, what you get from a full bladder with a transabdominal ultrasound is you get this beautiful as long as you don't have a big uterus full of fibroids. As long as the uterus is relatively normal size, you get this beautiful field of clear liquid to look through with your ultrasound, which makes a lovely field. And you can see kind of a lot of the periphery of the pelvic organs. You see the uterus, you see the ovaries, you see the cervix, you can see the top of the vagina, you can see all of that beautifully, but you can also see it pretty beautifully with an empty bladder. And if I really care about the structures like the ovaries and the uterus and the cervix, I'm better getting closer. So I'm better doing that transvaginally. So it turns out, do you get that much more from torturing some woman with a full bladder to get this transabdominal ultrasound? You don't. And I can't do a good transvaginal ultrasound in somebody with a full bladder. It pushes everything out of the way. Those of us who've learned how to do ultrasound, this was dramatically pointed out to me in a case where a resident did an ultrasound transvaginally with a full bladder, and we completely missed an absolutely, completely obvious ectopic pregnancy because it was kind of pushed enough out of the way that the transvaginal probe didn't get there because the bladder had shoved it out of the way. As soon as we had that bladder emptied, it dropped right down into our field of vision. It was like, wow, there it is. So for us, transvaginal is absolutely the way to go. It gives us everything we need for the sort of our pathology in the emergency department. And if that doesn't show enough, they can't quite get the periphery well enough, the adnexy well enough, they can take that, they basically flip the probe around, get the different probe, do it on the abdomen with an empty bladder, and they'll get enough of the extra, you're done. So full bladder ultrasound isn't necessary for what we need in the ER. To be frank, it probably isn't necessary for the others as well, but transvaginal is the way to go overall. Full bladder, don't torture people, don't need to. All right, what about this is a very common thing, and this is a huge push right now, educationally, nationally. Okay, there's a national push on education on this. I'm going to give you a scenario. 82-year-old woman lives at home with family. She's widowed. She lives with her family. They take really good care of her. She's usually pretty functional. Today, she's just not doing so well. She won't eat her breakfast. She's a little tiny bit confused, no fever. She just doesn't look so great. So family brings her to you, the dwindles. Okay, grandma's just not looking so well today. You start the hunt because you know that dwindles today can be depression, sepsis, an MI, a ruptured aneurysm. I mean, it can be almost anything, a stroke. I mean, there's just a lot of stuff that can happen. You start to do your investigation, and all you find is a urine that has 12 white cells and 1+ bacteria. Woohoo! We found the answer. Let's give antibiotics. Wrong. It turns out, this is, and I am totally guilty of this. I did this for decades. Oh, yay. I have a reason, that little tiny, she's not really having any urinary symptoms at all, but she's just a little off today. It must be from this UTI. It actually turns out that's not true. So the Infectious Disease Society of America, I think it was either 2013 late or 2014 last year, put out a guideline for treatment of asymptomatic UTI, basically, which is not just bacteriuria, it's also pyuria. Okay, so both white cells and bacteria. The only people you should be treating with that, if they're asymptomatic, truly, there's no urinary stuff, there's no fever, there's no flank pain, they're truly, honest to God, asymptomatic. The only people you should treat are people who are pregnant, and you treat all of them, or people who are set up to have some sort of urologic procedure, invasive urologic procedure, cystoscopy, something where they're going to have a procedure. Otherwise, it turns out that most of these cases aren't a true infection. They're just not. People get especially in women, our parts are very close to each other down there. It's not at all uncommon for a little bit of bacteria to get in there. Your body gets rid of it, it's gone. Okay, and it probably does it over and over and over again all the time. Once you're symptomatic though, and that may include not just dysuria, which is what we're used to, or urgency, frequency, but if there's a fever and I don't know what, now I'm getting into a different ballgame. Now I have a fever, I'm gonna send that urine for culture. I'm gonna go ahead and treat, knowing that may be the source. I'm 100% sure, but now it makes more sense. Or flank pain. This asymptomatic sort of UTI stuff really has been, because it's a huge reason that E. coli, I don't know where you work, but our E. coli, where I work, is scary. It is scary. Our failure rate for outpatient treatment for UTI has gone as high as 20 to 25%, even in young, healthy women. Scary. So this is a push to make us quit treating inappropriately stuff. And I'll tell you, in somebody like this, an older woman with the dwindles, It keeps you from making two mistakes. One is giving antibiotics that aren't necessary, at least for that problem, and the other is diagnosing something that isn't really causing her trouble. You're going to have to keep looking a little further to see what's causing her trouble. So and there's a whole guideline out there. If you're interested, it's out. The IDSA really hit this hard last year, and I think it's really worthwhile. It's a big problem. All right, to get out of the urologic system for a second, and just the little bonus one that Rick threw in here is banana bags. I cannot remember the last banana bag I ordered. I can tell you I ordered thousands of them early in my career. Working in a county hospital, we saw alcoholics. We see them all the time. It turns out that a couple things about that yellow bag. One of the things about that yellow bag is patient privacy. It's like putting a little neon sign that says alcoholic, here. This big neon bag that basically, it really is. It's that everyone knows that person has an alcohol problem. It is no magic to put it in an IV. Give them a couple Flintstone vitamins and you're done. Okay, you basically have tackled it. The thiamine issue, we are more likely in this country to be thiamine toxic in our alcoholics than we are thiamine deficient. The amount of we see them so often in our ERs, they get thiamine so frequently that they've actually looked at true B12, folate, and thiamine deficiencies in our alcoholic patient population. There's some studies in here. It is vanishingly uncommon for that to be the case. Now, however, I have to tell you, I have seen Wernicke's, I have seen Korsakoff's. In fact, I see it relatively regularly. It doesn't mean that they're not thiamine deficient, but that you can go ahead and give as an IM shot if you want to. You can give it orally if you want to. So the reality is that whole banana bag concept, you can do almost all, in fact, all of it, you can do pretty much orally. So there's no magic to the banana bag, and patient privacy-wise, it turns out to be kind of an issue. So that's sort of the gist on that. So the general gist of all of this is, challenge authority, rethink things. A lot of things that we did because we were told to do were lies. So rethink it all, it's kind of fun. And that's it, we're done. Thank you so much, everybody. This has been great.